Um, I'm actually without my sidekick today, Scott Palmise. He's working on a few different timelines, so unfortunately he couldn't be here with us. However, I would like to make this as interactive as possible based on asking you guys some questions as well. And how I would do that is I'm actually looking for you to raise your hand, which is going to be right there in your the little chat box. All you have to do is click on the hand, and when I ask the question, and that'll start to give me a some feedback here. If you have any specific questions for me, go ahead and type it right into the box, because since I'm going to be really reviewing 3 different topics within this session, I'd love to kind of go off topic and ask any questions and strategies that you guys have seen, answer them. So to start off, how many people here, and again, use that hand, how many people here has it taken 6 or more months to find a physician to be a PI or a SubI on trials? Go ahead and hit that hand. Let's see, I know, up. See the hand? It says raised hand. You can click it right there. Okay, got 1. All right, 6 or more months. Love it. So maybe what we can start to talk about, if you want to put some questions in here as I'm beginning to talk about this, I'd love to hear any ideas of what particular methods have you seen be successful in identifying doctors. So that could be, do you use Indeed? Do you use some sort of staffing agency? Have you used LinkedIn? Have you used other targeted physician websites? Maybe it's CenterWatch, even ACRP. Indicate any methods you've seen work. I'd love to kind of review them specifically. So the first item I want to talk about, though, is when we're reaching out to physicians to be PIs, SubIs, or even potential referral sources, we actually don't focus on the fact that we need a doctor for a specific role right away. So what does that mean? We essentially will, regardless of the type of PI or SubI we may need in-house, we will first start by thinking about how can we educate the physicians on clinical trials. So we'll create a focused presentation, have a lunch and learn, create a number of different flyers that we're going to send out to clinics. We're going to do it the old school way and send them out through the mail. And then we're also going to do a number of different social strategies to try to engage with those clinics. But the whole focal point is let's host a lunch either at our facility, or we would want to host that lunch at a potential nearby coffee shop, restaurant, whatever it may be. Sometimes you're even going to go to them if they're interested in learning about research. The presentation should consist of really all the details about your site. You want to make them feel excited about research, and also think about the fact that maybe they don't have a lot of experience in research altogether. As we have always seen, there's 2 major types of physicians that we would break in the category into. We know there's a number of other ones that fall within the category, but there's the physicians that have gone into retirement, and they still may want to work a few different hours in research. They may be a PI, they may be a SubI, but they still want to do physician-related activities, but obviously their workload is substantially decreased when they retire and just don't know that research is even an option. We've seen, meeting up for coffee, breakfast, something a little bit more casual where you're going to have a 15, 30-minute conversation, maybe even an hour about research opportunities that may be at your site in the near future is always very helpful. The others are more of your younger physician that may have, completed residency and have limited experience with research, probably at more of an academic organization. And there, we've seen a lot of exposure being driven for that type of physician where you can build a business around, happening through LinkedIn, actually through ACRP, CenterWatch, some of these other organizations that are specifically within our industry. So going back to it, though, the focus presentation, has anyone tried that strategy before where you have actually created a presentation? You're going through the details on your site, who you are, what kind of research you're doing. So what kind of therapeutic areas do you have? What is the support system around that physician responsibilities? maybe even some limited details on the compensation model for physicians. Has anyone here ever done that method before? And if you could, again, hit that that raised hand button that's going to be right there at the top. And if you haven't, that's okay. It is a, being that this topic is called proactive strategies, we've seen this work. We essentially, to make always the long story short, is when you go into it thinking that I need a PI and you're going to sit down with a doctor and you're like, how do I get this doctor to be a PI? It's not always the best strategy, because you may want to identify what opportunities are even there first. And even if that doctor can't be a PI and can't dedicate the time that you need, leave the door open for referral source opportunities. So always do want to make that clear. So we started to talk about the presentation. I like that I saw a few different hands raised, not everybody, on the fact that they've done this. And to clarify exactly what those areas are in the presentation, experience, put in your reputation, what are the support staff, so that's your coordinators, your regulatory, really the entire operation that's going to be around that physician. Make them feel trusted, that this is a system that's experienced. I'm going into, and I'm going to feel that when I'm signing off on that 1572, and if there's certain things that I might be concerned about when it comes to the oversight of a trial, is I really trust in that team. Who are the typical pharma clients? I know this is broad, but if you're working with Pfizer, you're working with Bristol Myers, you're working with companies that are a lot more reputable, then you're going to see that they're going to identify that these are companies that they're already probably pushing out medications on the approved side, so they're going to feel a lot better. And again, that trust factor comes into place. Treatments in the pipeline. Alzheimer's is always a favorite one that I've used, since there's not an approved medication out there for a long time. But you're going to more talk about what is in clinical trials and what types of treatments may be great options for their patients that do have that unmet need. So CNS physicians, if you're looking for a psychiatrist, neurologist, that Alzheimer's might be a lot better for something that you'd bring up. Industry trends and competition is always a big one. What kind of compounds are you seeing? We could easily start talking about oncology, things like personalized medicine. You want to make the physician feel excited about something that they're going to be able to get themselves involved with that's going to be groundbreaking. The job expectations. This is a big one. I'm actually going to review this one in a little bit more detail. But job expectations is important for a number of ways. I feel that this is an area that not all sites are doing a great job with. Because when you're communicating the job expectation to a physician, if you're going by this advice that I'm sitting here telling you, and you're talking about Pfizer, you're talking about Bristol Myers, and you're showing them every single study protocol that comes across your desk every time you get a feasibility questionnaire, you may make them frustrated, and you may make them feel they don't understand the timelines that are associated with the things that we deal with on a consistent basis. So you don't want to almost chase them out the door before they even get started. So I'm going to jump into that one in just a little bit more detail. Compensation, of course, they all want to know about compensation, but I've always felt when I've actually given these presentations before for sites, when you get in there and you have you push out all these flyers, you get 6, 10, maybe even 20 physicians in the room, variety of expertise, so you have a neurologist, you might have a rheumatologist, you might have a nephrologist. The questions that come to you are always the big indicators on who is the best partner for you. Let's go into that for a second. One would be on a positive side, if a physician's asking about, and you can tell they're excited about some of the treatments that are in the pipeline that you're talking about in your presentation, and you can see that they're really taking the ideas that you have and kind of running with them based on how they treat patients at their own facility, then that might be one of the key indicators that this is a great potential physician. Now, again, these are indicators. Something that might not be a good indicator would be what? The physicians consistently ask about how much money are they going to make. How many people here, and again, I want to see hands raised if possible, but how many people here have done some sort of similar strategy? And that also could be or you're bringing a physician in for an interview, maybe you're going into a clinic and meeting with a physician, where you're actually, they're just all the questions are related to the compensation package. If you guys could raise your hands on that one, and I would be interested, again, based on feedback, if you've actually seen any of them turn out to be a long-term asset for you in the organization. To keep going, because we don't want to spend all our time on that, study budgets. When you think of the experience level of the physicians that are always going to be in the room, hosting a presentation like this, they're not going to really understand what the payment structures even look like for them. I know we did a session in December where we actually dove into physician compensation structures in detail, which I won't do here. But there are, as we know, a variety of ways to compensate a physician. There's the salary, essentially the full-time salary, which we see at more of a larger site where you probably have more fixed expectations. Physicians are going to investigator meetings. They have to do certain things just like any other employee for any other position. There's a certain expectation in the salary. Again, I said larger sites based upon the fact that not everybody can afford to have a physician on salary full-time, as well as the workload. There's the hourly plus the procedural basis, and then there's just the hourly. And again, there's a number of benefits that we see for each of those, but someone that, sites that are smaller that may have 1, 2, 3 physicians kind of rotating out of a number of trials, we've seen the hourly plus procedural basis be very beneficial. But show them a study budget. Say, here's the typical study budget that we would get. Here is a potential opportunity of where you would see any kind of compensation working for us in the various roles that we consistently work with physicians in. So now let's shift it a bit. As you think about bringing now that doctor on board to your site, let's say you went through this process, you had 20 physicians all in the room, and 6 of them you saw were going to be a great fit. 4 of them may turn into referral source, opportunities where they don't have the time to dedicate, but they're interested in setting up a structure with your team where they're going to be able to, work with you on hopefully benefiting their patients in some way, shape, or form by offering clinical trials. There's the other aspect of the fact that you need a SubI, you need a PI. Even if you need a PI, please start the physician as a SubI. Tell them we got to work up to that expectation. We have seen when you need a PI, have them be a sub for 3 to 6 months. Think, we're going to start you with a certain number of hours, and here's the expectations that we need to see from you from 3 to 6 months. And that 3 to 6 months is a pilot period. So you need to see if they're actually going to work out, and they're going to learn about trials. I'm sure a lot of people here, actually, you know what, let's do another hand raised. How many people here have had physicians think that clinical trials are a heck of a lot easier than they are? Can you please raise your hand? I'm going to repeat that one more time because I'm sure almost everybody would raise their hand. How many here have worked with physicians where they think that studies are going to be a lot easier than they actually are? So the time commitment, as most physicians we know, may be juggling between a couple different organizations. Okay, there you go. We got a lot of hits raised. So that is why I recommend all the time, start them between a 3 to 6 month, pilot period, and give them 3 to 5 hours a week. Add them to a few studies that you already have, and you need to see if the personalities, the cultures, all the different aspects regarding how they work with your team are really going to be there. And don't overset the expectation. I've always said that we've seen some sites fail substantially because they'll ask the doctor to be send all their patients immediately through their practice. They want the physician to jump on several studies up front. They want the physician to also support in doing other activities that may be a little bit more prone for a study coordinator. So really iron out what those expectations might be, because you have to think that 3 to 6 month period is we have to build up the CV, and you have to tell the physician that, based on whatever the experience level is, and since this topic is research naive, we need to build up the CV, and some of the trials that you're going to be doing may not even be relevant to this, to your degree, to your board certification, we should say. And you're going to be on site, or we're going to come to you if you're more of an SMO model, where we're actually going to be coming to you and spending time as well. Think easier trials first for any new physician. Again, don't think of trying to make all the money in the world from the best study or the longest trial. Don't put them on a 2-year trial. Put them on something that may be more of an observational trial. Something that you may have lower or mediocre enrollment expectations. So that would be, to me, anywhere from 1 to 3 to 4 patients a month across, 4 to 6 month recruitment period. Don't put them on a study that you have to, you're going to jeopardize your relationship either. If you're trying to get in with Pfizer and you get your first opportunity with Pfizer, don't put your new physician on it, because say that physician ends up not working out for the various reasons we see people not working out for. I can't really, I could talk about that for a long time, because I see sites making that mistake consistently. Is please start the physician on easier trials. Let them know this is a long-term commitment for both of us. But at the same time, build them up, as you go, thinking of, we need to build your CV. So the more studies, easier, shorter, the faster our chances are to build up the CV. So of course, keep your reputation in mind is always the biggest thing, because switching a physician from having to be inside as an SMO model, having to be inside another clinic, and you're sending your coordinator out to that office, and then that physician says to you 2 months in, this is a lot more than I thought I could handle. We need to stop all trials. As you guys all probably know on the line, that is a very fast way you can jeopardize your relationship, and that's the last thing you want to do. So even if you have intentions on doing studies in their clinic, start doing studies right there in your office, and compensate the physician for a couple hours a week. Start small and then build up together. So a big area that I did want to hit on is the how to know whether, how to know which physician you should be submitting for studies. I know, in thinking of this conversation, I didn't want to focus a lot of time on business development, but how many, I guess what I'm going to try to say here is there's a lot of circumstances where a physician is a SubI, and that relationship has worked for him or her as a SubI for a long period of time, but you get this trial and you need to add that physician as the PI. A lot of sites you see consistently will just think, nope, my physician's only here as the SubI. He or she does not want to be the PI, but that may have been a conversation that you had 2, 3, 4 years ago. So in an easy sense, what I'm trying to state here is always consistently revisit and do reviews with your physician where you're consistently asking them if an opportunity arises for the right study for the board certification that you are, and we have an opportunity together to land that trial looking better with you as the physician. Can we add you to that study in that way? Can we get potentially some more from you? In this 4 or 6 month, maybe this is a year now, 2-year study. As you think of maximizing your chances of getting any trial, one thing, as we discuss this, that we see consistent is we're not asking as sites who, if we have an internist and we have a dermatologist and we know we have an acne study that we're submitting a feasibility for, and the internist has all the experience, the dermatologist we just got on board within the last couple months, ask the question to the sponsor and CRO. Here's the circumstances that we have. Here's the experience that we have. Our internist is the more experienced clinical researcher, but our dermatologist is the one that's actually going to be doing the scales. Who should we have as the PI on this trial? We don't ask those questions enough. I can't stress that enough, because we are consistently just putting the internist and thinking, well, they're going to be the best fit for the trial because they're our experienced clinical researcher, they're our PI, the dermatologist is only in there a couple hours a week, whatever it may be. I would ask that question and then think, when you're submitting your feasibility, what are the best chances of us getting the study? because one of the biggest shifts in the evolution of just completing feasibilities these days is that acne trial where even 5 years ago and maybe even 3 years ago, an internist or a primary care physician of some sort could be the PI. We don't see that as frequent now because why? Well, we need the dermatologist to do the scale. We need to understand the type of severity of acne that the patient may have when they come through the door, and that just might not be something the internist or primary care physician is trained to do. So think about that when you're submitting your feasibility assessment. If you're not asking the question of the sponsor's hero, or you work with a company who's fighting on your behalf as far as the business development strategy, have them always perform that and make sure they're asking those questions. And it's the same when it comes into patient population. It's the same that comes into any procedures that need to be done outside of just doing scales. So that I'd say that's a big item that you see and you may not be always thinking about. If anyone wants to see and is interested after this presentation, I can send you the questions that our team asks to a sponsor's hero, where those key indicators such as what type of physician should you be submitting are a part of those questions. Essentially, it's the BD questions after we've identified there's a trial opportunity. So if we want to use an example, Pfizer has an acne trial, and they say, hey, Christian, we need 10 sites for this study. These are the questions that we would follow up with to Pfizer prior to introducing any of the facilities that we work with to them. So be more than happy to send them over if anybody's interested. So let's shift it a bit. I like always a lot of different questions, and now that this webinar platform is a little bit more interactive, almost like I'm giving a presentation at a conference, shoot some questions over through to me about what anyone else would want to know about other strategies to find physicians. While you're doing that, because I know in the last webinar we had a lot more questions than we have so far today, I'm going to dive on a few other things. When we're trying to find physicians to partake in any role as a PI, SubI, or as a potential referral source, how do I push that interest out there? And still the old school strategies we see are the best. So host some sort of lunch and learn, or show up at the clinic, try to talk to the physician, go to some sort of, I know there's a lot of advocacy and support groups. We see a lot more sites participating in events associated with them, but get the interest out there, but keep it general. Don't try to segment yourself and think you only need a PI, you only need a SubI. I'm only looking for referral sources. Meet the physician, see if the personality and the opportunity is there based on what your site's already doing, what that physician's most likely already doing, since they're always going to work a number of different roles, and then think, well, how can we bridge that gap? How can we work together? Let's start somewhere. Okay, here goes a good one. I am considering opening an individual research center. How do I figure out what to pay the PI? Example, he has to be there for a physical and do some assessments. What should I pay? So that is a consistent, great question. How many people here, and let's use the hand again, how many people here have a site that they've opened within the past year or two, if you want to raise your hand, or are considering opening a new site? Perfect. And again, click that giant hand there. And while you're doing that, I'll start answering this question. So, there's a reason why a number. So here's the potential. I don't know if I ever want to say the funny thing about it, but ClinEdge does have a staffing arm of the business. When we first started ClinEdge, we had never intended on necessarily offering this service, but so many sites have come to us because of the other services and say that staffing agencies just aren't able to help us find the best staff. And we've noticed now as being, we've always helped sites with more of a going through the efforts that we know that are needed to get a physician. However, once we formally launched this division in 2017, we realized that nobody really helps get physicians. And then we started to think, well, why is that the case? Because we've always seen a lot of success. Well, your question is the exact reason why. It's because we don't know how much the physician's going to get paid through a certain duration of the business. Because as you guys know, you're probably going to set that physician up on some sort of plan where it's going to be a percentage of revenue for studies they're working on, or an hourly fee that you know you only need them for based on the work that you have. So again, to directly help you on this question, I would generate a variety of interest within your community that you are seeking partnerships with physicians. Your tagline probably literally might say, seeking physicians to get into clinical trials, contact me for more help. Would be, when you're going to put in there that you're going to host a presentation on an informational session on clinical trials for him or her to understand if this is something they're interested in. Again, within that presentation, talk about the various compensation strategies that are out there. However, start the conversation and state, I've only been running a site for a year. I've been running a site for 2 years. We have gone from here to here, and here's where we can go with your help as well. With your expertise, with your board specialty, there's all these opportunities in these other therapeutic areas. Show them some budgets within those potential therapeutic areas that you probably don't have, and then start small. We can do a hourly plus a procedural fee, and you can use clearly some simulated examples based on the budgets that you have. And I would also encourage everybody on the line here, since I know not everybody has access to these budgets, is if they're not in that therapeutic area, reach out to me. I'm always happy to share some blinded study budgets from therapeutic areas that you might not have that expertise in, but you're going to run a simulation with them. If you're going to give them, let's just say for the sake of this conversation, 8% of the study budget, then show the Excel spreadsheet and say, if you work with us and you dedicate 3 to 5 hours per week, you do these scales with us during these periods of time, here's how much you could potentially be compensated if we were to have this trial that's actually out there today. Second question, what is a decent hourly fee? So I can answer that in a couple different ways, and I'm actually going to look over on my computer screen here because I have this sheet that details out all of the different types of compensation structures for each physician specialty. So Marilyn, if you want to shoot me an email at Christian@clin-edge.com, I can send you literally the breakdown that we have at a physician, at each individual physician specialty. And this is just a generic simulation. But start the physician anywhere. I'm going to say a primary care physician to be simple and easy today. Start it anywhere around 150 to 250 bucks an hour. Specialist, usually you're going to go higher than that. All right, I see we have a minute left. Any other final questions today? Okay, well, I thank everybody for joining us. As I said on the last one, we're doing this every single week. Simone and Bailey, the team here, has been doing a great job setting out all of the different topics that we're going to be doing weekly, essentially this entire year. So far, we have January's and February's topics finalized. So anything that's going to be relevant for you or any other team members at your site, we would hope that you guys attend. Hope that you learned a lot today. Feel free to always reach out to us if you have any other questions to keep the conversation going. And thanks for attending this video webinar. Have a great rest of your day.